Hello, everybody, and welcome. This is not Tales from the Heart. This is not a big hearted warrior tour. This is a special occasion. This is an HCMA recognized Center of Excellence official launch. So, we are excited to welcome Indiana University Health to the HCMA recognized Center of Excellence community. And today we have with us its director, Dr. Roopa Rao. Welcome and tell us about your program, please.
Thank you, Lisa. This is indeed a big day. And Lisa, we have been working on this for more than a year. And I want to start this by thanking Lisa and her team. The reason is, this is something that Indiana University needed. So when we started this a few years ago, I wanted to put a program together. But the Center of Excellence, pursuing that dream, helped us to streamline the process, made us aware where we need to work on and close the gaps and look for things in the future that we can build on things. So I want to thank you wholeheartedly for what you're doing to this community and to the educational institutions and to our patients to provide that care. So about my program. So Indiana University Hospital, they're all integrated. That is the beauty because it brings that collaboration of academic medicine and providing the care for our patients in a well-rounded manner. So the physicians of my team, I have few people who are very much interested in providing the care. And, I should say, I've been practicing for 15 years. And in the last few years, a lot of exciting things are happening in the treatment for hypertrophic cardiomyopathy. And when you see that the patients are, feeling better, it's making a big difference in the care of their health, their journey, the treatments that they never were able to pursue. But now, because of that, their trajectory is changing. Simple things like I'm going to now the baseball game with my grandson. And that, look on their face and they look at me as I'm like, oh, you're something like a god or something, that pushes you to do this and that joy and the reward. And this is exciting time to be in this field. So there are more and more physicians who are interested. So I have a very good team with physicians, Dr. Nayak, Dr. Peru, Dr. Alonze. So these are some of the physicians who will be seeing patients.
What are the roles in the program? So who's in EP, who's in medicine, who does what?
Yeah. So the big component of this is inherited disease. So we need a good genetic counseling team. We started actually with one genetic counselor. We now have a group of 5 genetic counselors.
Wow.
Yeah. And the process is very simple. The appointments, the testing, they make it work for you. And it is in a very timely manner. There is not a big, long waiting time. And then EP, electrophysiology, is big part of hypertrophic cardiomyopathy care. And we have a very well-recognized, qualified team of electrophysiologists to, atrial fibrillation care, ablation, to complex VT, which can happen with hypertrophic cardiomyopathy, even ablations in very, very sick patients, like first, second, third ablations, because we want to avoid going to the other end of heart transplantation or replacing the heart. So we want to do everything to avoid that. So I am very blessed with a great team of electrophysiologists. And we also know this is something that, you're dealing with this diagnosis, nutritionists, psychologists, psychiatrists. We need to provide that well-rounded care and the support that these patients need. And the beauty of this is the patients can see them right where they are seeing the physicians in the clinic. They don't have to wander in the hospital finding which place to go. And then I have a great group of nurses. Oh, yeah. I mean, I can't thank them enough because as physicians, we come up with a treatment plan, but executing it, especially in the era of a lot of medicines and a lot of things that are available, a lot of coordination, juggling with the insurance and the patients, I want to make sure that they are heard and they're getting the help in a timely manner. So my nurses, Ashley Mooney and Amanda Reagan, they're excellent. They're excellent. And we have a good pharmacist who goes over all the medications and fine tuning from that perspective. So I would say we are a very well rounded, structured program. And the other thing that I would like to say is, this is a disease that happens at the time of puberty. So we have a very good children's hospital, Riley Hospital. So a lot of patients, they are taken care of at Riley Hospital. They reach adulthood, they transition through the adulthood. So we need that transitional care. And that is another aspect that we pay attention to because as care as a kid and transitioning to adult, it's a tenuous period. So we keep that in mind. But the communication is great because the geneticists, they take care of the pediatric patients and the adult patients. So it's vice versa. Sometimes we know the kid is diagnosed with hypertrophic cardiomyopathy, and then the parents need screening, so they come to us. So there's a easy pathway to navigate that transition and the care. And when the children, the adults, they transition, they come to us. So the communication is good, and that pathway is very straightforward. So
You've
these
got a
are
multidisciplinary program with a pediatric partner, although we've not gone through the pediatric program yet for Center of Excellence status, but we know that they have good knowledge, and hopefully we'll work on that in the next year or two. But you have great collaboration there. For those who are not aware, a lot of innovation in implantable technology really happened in Indiana between the work of Dr. Doug Zipes, who I'm happy to say I've known for many years. Hi, Doug, if you're watching, and Prasowski, who's also worked out of Indiana. So you've got a lot of EP prowess in the state of Indiana. And I've always been frustrated that we didn't have a functional center of excellence. And I tried for many years through different people with the program to get it moving, and it just wasn't the right time. And I'm so happy that of all of the pins on the map, we finally got I didn't put your official pin in the map yet. I'm gonna go take a picture of myself doing that later. But, it's an official pin in the map, and, your program is still on the smaller side compared to some of the other national programs, but it's growing and it has the elements to grow and flourish in the coming years. And I know you've done some clinical trials in the past, and you have the infrastructure to do more. Would patients, should they check in 6 months or so and see what trials might be available? What's happening?
Yeah. No, thank you, Lisa. This is a very important part because we have to advance the field. We have been part of some clinical trials like Odyssey and Discover HCM, and we have published, case reports and editorial commentary. Basically, Indiana University has that infrastructure to support any research trial or anything that any institution would offer. We have very well trained coordinators, and more than anything, the administration and the university are heavily interested and invested in promoting research. And in fact, we have to report every year what we are doing, and there is a very heavy emphasis. And when the administration is very supportive, that's when things will align and will happen. And more than anything, I have a group of physicians and other members who have that aptitude to advance the field. So it's a good combination. And I'm looking forward to taking this to the next level because we are heavily involved in research in every aspect of cardiology, heart failure, or heart transplantation. So that is our goal and that is our aim. And hopefully at some point we will get there. But if there is anything that we are open to, and hopefully in the next 6 months, we will be talking about a few more things.
I hope so. There's a couple of active trials and there's some new ones coming up. So hopefully, as our pharma partners take a look and see what centers are available and where patients are sitting that are eager and interested in participating in research, that's where we have the best likelihood of getting good alignment. So I look forward to hearing what trials you may be available to participate in the future. We know you the clinical opportunity. I'm going to change my slide here. For anybody who is looking to get a second opinion, evaluate potential care through Indiana University Health, here is your phone number. Here's where you're going to call, set up an appointment. Rupa, who's on the other end of the line taking their calls? What's the team look like?
Um, I am not able to see, but if my clinic nurses and my coordinator for the program, they should be on the line as well.
No, they're not here now. So I was just wondering if you could tell us the names of the people who would be answering the phones when somebody calls in. Is there 2 or 3 people, or is it a switchboard? Who are they going to get?
Yeah, no, this is definitely the number that you see here is a direct line to our clinic. And our clinic is very specified and to hypertrophic cardiomyopathy and heart failure and transplantation. So don't be alarmed when you see that, because we do cater to a little bit wide variety of patient population, but it is still a very integrated, individualized care that you're going to be getting. So when you
Fantastic.
call, yep, when you call, there will be few people that you may hear. They're extremely good. Benita Mullins, Sarah Lamore, Chrissy Harris. And sometimes, if the patients have more questions, you may be transferred to our nurses, who I already mentioned, Ashley Mooney and Amanda Reagan. But I'll tell you, when you come to the clinic, you have to be prepared because there are a lot of puzzles. They try to trick you with those puzzles, those cool puzzles. But just to let you know, we are a friendly environment. And if you have any issues or troubleshooting, this number is a number for our nurses too, and they will take care of you.
Fantastic. So we know that you are, I believe you came on as program 59 because they don't always launch in the order in which the numbers are. We're at 60 programs now. So there was one after you and 2 in review right now. So this program is growing as centers of excellence grow across the country, and each individual program is growing within its own footprint and infrastructure. I have long been frustrated over Indiana not having a center. And when we met, I'm like, girl, I need some help there. We've got a lot of people who are traveling an awful long distance to get care. Now, sometimes there might be care that's specialized, and you might need to fly out of the area still, because complex surgeries do require, an expert eye, and we're not quite to everything we need to do in one place right now, but this is where you're going to get your care, your diagnosis, your management. And that care can go up to what level? You can go to transplant in Indiana, can't you?
Yes, yeah, we have a very well, heart transplant. Actually, we have it for more than 30 years now, and we have more than 750 patients transplanted. So, with the history of advanced heart failure therapy starts, it aligns with the history everywhere else.
Yeah.
So when you come here, you can be confident that you'll be taken care of. We make every effort to avoid heart transplantation. As I said, I would like to share a story of my patient, who, this is what really made me very excited and enthusiastic about this field. I'm a heart transplant physician as well. So a patient came to me with shortness of breath, can't even walk inside the house, needing heart transplant, very thick heart muscles and intracavitary gradient. So at that time, myosin inhibitor, mavacamten, was just released to the market, and that patient is my first patient that we enrolled. And
Wow.
within few weeks to months, we are not talking about transplant. Almost 4 years now, I see a smile on the patient's face, can climb the stairs, and the patient is working full time, and we are not talking transplant. I know at some point we will be, just because of what anatomy is and other things. But that is what we are here to do. We had another patient, we actually published a case report, non-obstructive cardiomyopathy, but MR, not a surgical candidate. We even put a mitral clip. So there are very, very few cases of exploring mitral clip in non-obstructive hypertrophic cardiomyopathy. So again, that another patient came as a referral from another center for heart transplantation. So what I'm trying to say is we are here to look at all aspects of care. And sometimes, as Lisa said, very, very complex surgeries. If we are not able to offer, then we will help our patients to find a home where they can be taken care of. Our team will help them. And I'm actually in constant touch with other institutions which can offer this care, and we will help them to get to that level of care. Um, so, and when it comes to heart transplantation, we are a center of excellence as well. We have transplanted patients with hypertrophic cardiomyopathy, multiple examples. So, if that is what is needed, then you don't have to go anywhere else. And my team, including me, we provide hypertrophic cardiomyopathy and the other extreme of heart transplant. So, one place, familiar people.
We have a comment from a member of your team who's joining in from LinkedIn. Excited to be part of this amazing program, says Bradley Weissman. So we want to make sure that everybody gets their moment here. And I believe this is going to be a new patient. If you haven't seen her already, she will be. Kathy lives in Indiana, and I actually was traveling in the Midwest, and somebody might have been getting married, so I might have crashed a wedding at one point in Indiana, and it was Kathy's. So
Okay.
you got to take good care of that one. She's a special heart. They're all special, but all right. I don't go to everybody's wedding. I'll just say that much. So we are excited to have you as part of the team. I do have Demi going to drop a link now on something unrelated. It's feedback that we need from patients on our upcoming patient-focused drug development meeting with the FDA that will be focusing on gene and RNA-based therapies for hypertrophic cardiomyopathy and also for other thick heart muscle disorders. So we're representing Amyloidosis Foundation, Research Foundation, Dilated Cardiomyopathy Foundation, SADS Foundation, Danon Foundation, FARA, which is for Friedreich's ataxia patients who have cardiac manifestation. So if you or anybody in your family has any diseases related to genetic heart muscle disorders, feel free to share the survey with them as well. And we're taking comments up until the end of April. So please take time and do that. Yeah. Okay. So Kathy has not called yet, but she's going to be calling. And when Kathy Hall shows up, Roopa, you keep an eye on her.
Sure.
Thank you so much. Okay, Kathy, she's got you. Promise. Okay. Well, we have her here for a few more minutes. If anybody does have any questions, I see we have a bunch of viewers now. If anybody has any questions about the Indiana program, we're happy to take them. And in the meantime, Rupa, let's just talk for a minute about what you kind of opened with, the process. And we don't always talk about the process of becoming a center. And it's a little mysterious to the outside world because it's behind the scenes, and a lot of it is personal conversation. And where are you at? And where's your institution at? And then it's data collection and systems evaluation. And when we stop and we do those processes with the program and we guide their attention, it allows them to make the changes that will be needed to optimize the patient flow through the program. I know what it looks like from my side. What's it look like from your side of the table?
No, very good question, Lisa, because this is the key part of becoming a center of excellence, because it helps you to put the program together, makes you understand where you need to work. And I enjoyed that process because I like structure. I just don't like to do things haphazardly, and it brought that structure, and also to make sure that we are not missing anything. So some of the things that I can think of that we had to work on, even though we had a protocol to scan the hypertrophic cardiomyopathy patients, the echo lab is number one. We want to make sure that sonographers are trained to scan these patients, and that if the sonographers don't show me the gradient or the images are not good, then it makes a big difference in the care of these people. And also, I think the sonographers has to be OCD to find that gradient.
Yes.
I'm proud to say that our sonographers, we identified a lead sonographer because we need to have one person own it. And I worked with that sonographer on number one, developing the protocol. And it is not like we have to do it all by like ourselves. Like
No.
the Lisa Stacy has helped me so much in getting the protocols from other institutions. And they were kind enough to share their protocol and put everything together to kind of make sure, tailor it to my program, along with the sonographer. And a goal-directed Valsalva is a big thing that our team adopted. And the good thing about Indiana University is we have presence throughout the state, like a spoke and hub model. So we have a lot of patients that are being referred to us. But we also keep in mind the distance that these patients have to travel to seek the care. We make it work for them. So we have collaborated with other centers, other echo labs to streamline the process in case the patients are not able to travel. We want to keep that in mind, especially winter, there's a snowy weather and we need to get an echo. So we actually have made great progress in disseminating this protocol to other centers within IU. And I'm amazed how much they're willing to adopt and accommodate this and make it part of their echo lab as well. So number one, I think we started with the echo lab to have that protocol, the goal-directed Valsalva, and making it right. And then CPET, cardiopulmonary exercise program. So we do have a very good sports cardiology center. Dr. Kovacs leads it, part of a lot of trials and very well structured. Some of our patients, we don't know if their fatigue is, how much of it is in, quantifying that fatigue and assessing their exercise capacity. And CPET, we have a very well structured CPET program. It's all in the part of the same area, and also to assess hemodynamics through the exercise stress testing. So that is something that we developed as part of this developing the protocol and becoming part of the Center of Excellence. The same thing holds true for MRI, making sure we are reporting the amount of late gadolinium enhancement and building a structure to that. So that's the echo part. And then the genetic counseling. As I said, we are doing so much more of genetic counseling now. It could be inpatient, it could be outpatient, and also like the referring centers. I want to share a story. A patient who was diagnosed with hypertrophic cardiomyopathy for like 20, 25 years now was seen at a peripheral hospital because we have outlined a structure for genetic counseling. Even the referring physicians can order the genetic counseling to the same pool. The physician ordered genetic testing. The patient has carried the diagnosis of hypertrophic cardiomyopathy for 20 years. Yes, surprise. Genetic testing was, made a big difference in the
Yeah.
diagnosis. So change the trajectory. And Fabry's disease came back as Fabry's disease, and now an enzyme replacement. So basically, now the genetic testing, we have 5. Because of this, we have increased the number of genetic counselors. We have good, robust 5 different genetic counselors, and the wealth is being disseminated, the knowledge is being disseminated, so the referring physicians can order it and not delay the care.
I think you bring up an excellent point there. We talk about HCMA being the home for the big-hearted, and most of our programs are the entry point for the big-hearted. It's all the thick hearts.
Yeah.
So the very first thing we are asking ourselves when somebody comes to our door here at the HCMA, and as they go to an HCMA recognized Center of Excellence, why is this heart thick? Let's start there. Let's look at the genetics. Let's prove or disprove whatever it is we can, and then we can move on to the targeted direct therapy. And this is one of the reasons that I believe wholeheartedly, literally have dedicated my life to this, to develop these care models that start with asking that first question, why thick? And then which pathway? And when you have a team that understands it's not just a thick heart, and you start from that, okay, what are we unraveling here? But then you know where to put everything when you find it. Amyloid, Fabry's, HCM, Noonan's, Dannon's, so mitochondrial diseases of the children. Like there's so many retinopathies. There's so many reasons for the heart to be thick. Knowing why is critical. I do have, oh wait, who's Ashley? Is this one of yours? Hi, Ashley. Ashley the RN. Welcome, Ashley. We got your people on the back end. I do want to bring a full circle moment here. Back in the 1990s, a lovely lady named Lori, spelled the same way my sister spelled it, was living in Indiana and diagnosed with HCM and called for some input. Her daughter was also diagnosed, and she has family living in Indiana today. She's down in Florida right now, and her heart was on display on HCM Awareness Day here at the office because she's also a transplant recipient who donated her heart to be used for education. So, Indiana, your heart's in the box, at least one that was originated there. And Lori, thank you for sharing your story, your journey, and your heart with the community. And I told you I would get to Indiana eventually. Yay, today's your day, and we did it in Heart Month. And Kathy's asking a question. So, Kathy, we love Kathy. I love Kathy a lot. But Kathy kind of had some troubles getting diagnosed, and it might have lasted in or left some anxiety behind about trust in medical systems. Can you tell Kathy and other listeners how many patients are currently being seen in the HCM program and what the wait time for appointments is, and just give them a general idea of what the program looks like?
Yeah, no, thank you. It's very important. And also, we know that there's a delay in diagnosis, and it's not uncommon for patients to see many providers before the diagnosis is made. And I'm hopefully, I'm actually seeing a change in that structure because there are new exciting treatments available. I feel like we as a community are doing a better job in recognizing this disease because the echo lab, this is where it happens. They get an echo, and that's where we need to make a change. When the sonographers look at, oh, thick heart, let's do the strain, let's look at the dynamic gradient. So I do believe that the landscape is changing, and hopefully what Kathy observed may not be the case in the future. So to go back to your question, I started my journey in 2020 when hypertrophic cardiomyopathy landed on my lap because chief of cardiology at that time asked me if I would take over all the patients because the physician who was caring for them had a different opportunity and was leaving Indy. So at that time, I inherited 50 patients. So you can imagine, very, very small number. Then COVID happened and there was a little bit delay in, getting back to life. We have grown very well since then. And currently, and actually, the Center of Excellence has helped us. That designation has helped us because I do see the growth is really kind of being exponential. I'm getting at least 3 to 4 patient referrals every week. So currently, we have more than 300 to 400 patients that we are providing care for hypertrophic cardiomyopathy patients. So the wait time, we want to make sure our patients are seen in a timely manner because I can see the anxiety because you definitely Google it and the Google can give you wide variety of risks that can happen, sudden cardiac death being one of them, and that
Right.
can be very anxiety provoking. So we want to make sure that new patient visit, the first contact happens in a timely manner. Depending on the severity, within a week to maximum within a month is what we are aiming for that new patient appointment. I would say on an average, it's around 2 weeks. As we are growing, because this is our goal to keep the new patient appointment within a month and if possible within 1 to 2 weeks, we are making changes to the structure of the program and incorporating more providers. But that is the goal, and we do understand that it's important to see them in a timely manner.
We have a question from Elon. I think it's Elon. Is it Elon or Elon? You're gonna have to call me one day and tell me how to pronounce your name properly because I think I do it every other time I talk to you, I say it a different way. Do you have any opinions on AI analyzing echoes? I've seen some early technology. It's exciting. Is it ready for prime time or is it still a research tool?
Um, I think, it's, as you said, Elisa, I think it's exciting. I don't think it is, it's time yet, but will we get there? I think so. The power of AI is huge. I'm definitely realizing the technology is here to survive, but not ready for prime time anytime for sure.
Yeah. I've been following the technology very closely. It's very cool for normals. You can read a normal really well. It appears. Um, this is smaller though. This isn't system-wide data, so this is one at a time. But I do think it's going to help in diagnostics when the echo quality is way lower um, in certain parts of the country or certain parts of the world. So the AI will trigger who needs to get more advanced screening from one of your advanced sonographers. But I don't think we're there yet either. Um, yes, I saw the study out of Brigham, and it's still not ready for prime time. It's cool research. It's coming, but it's not in your next, you're not going to see it in the clinic in the next 24, 36 months. It's going to be after that. So we had a question about gene therapy that I mentioned earlier. We know that we've already dosed a handful or a little bit more than that, maybe 6 patients now with an AAV9 therapy for myosin binding protein C3. All the letters just got stuck in my head there at once. So we know that those patients have been out. I've podcasted with the first patient ever dosed, and Julia's doing well today. We're still waiting on readout from the trials that I think we're going to hear in a couple of weeks more. So when I hear more on that, I'll let you know. Roopa, do you have anything to say about gene therapy?
No, this is something that I'm, because it has made a big difference in other disease entities. It could be curative. And this is what I tell my patients when we counsel them. It may not be for you right now, but it will help your family to identify a gene, to know that this is what your family has. Because we know we need to do the genetic testing in the proban. So I'm hoping at some point it will be ready for prime time, like AI as well. But it's really something that I am looking forward to.
I am as well, but time will tell. Time will tell. So I think Lori's giving a shout out to some of her Indiana folks. I don't know. That just seems like an Indiana call out, Lori. If I'm wrong, pretend I didn't put it on the screen. So that brings us to about a half an hour that we've been chatting about the new program at Indiana University Health Methodist. You have so many names. So I'm just sticking with IU because it works for me in my brain. I'm just going to refer to it all as IU. The health system name changes that have been going on out there get a little confusing for some of us sometimes. So IU is where you will be in my brain. I really want to give a shout out and a thanks to many members of your team, including Dr. Kovac, who I've known for a really long time. A really long time. Back in the day when nobody else showed up at the talks at AHA and ACC about sudden death in athletes and the whole debates on who should participate and who didn't. Typically, it was Kovacs, Marin, Thompson, and myself in the room. The other ones could come and go, but we've been talking about this for a long time, and I'm in the middle of planning. Actually, I think I got to reach out and talk to him. I'm planning a webinar to discuss a recently published article about legislation maybe being off target in mandating particular tests for groups of people. So it's EKGs in athletes that's mandated right now in Florida, and the downstream consequences are really turning into being something quite substantial. And we've got a lot of kids DQ'd for absolutely no reason and a lot of money being spent and time and resources. So it's time to unpack how we're doing this and asking ourselves the question, can we be smarter and do this better? So I look forward to talking to him more because he is a thought leader in the space. And Kathy, I am so happy that you popped on here because you needed to meet our new friend, your potential new doctor. So please do call the office on Monday, Kathy, and I think you will be pleasantly surprised. Okay. Roopa, thank you. Thank your team. Thanks, Stacy, for all of her hard work on getting the Center of Excellence application all the way through the process. I don't know if you know this or not, Rupa, but Stacy and a couple of other members of our team received promotions at the beginning of this year. Stacy is now the director of the Center of Excellence program, upgrade from her coordinator position. And we applaud her on that, and her colleagues who also became directors, and Elena, who is our new chief operating officer. So the team is growing in their skills, ability, and power, really. So thank you, Stacy. Thank you, Demi, from being behind the scene, dropping all of our links today. Even Kathy says thank you, Stacy. Who we'll talk to Stacy later about where she is today and why she's not coming on screen with us. But that's a podcast for another day. Dr. Rao, thank you so much for your partnership, your collaboration, your ability to handle seeing this volume of patients. For getting through the process of Center of Excellence, through the administration, through the paperwork, through the site visit, through the post work, through the launch. And now the work really begins. So I look forward to many years ahead, lots of good work. And if you need kind, compassionate, capable care in Indiana, you now have a heart home.
Thank you so much, Lisa. I can't thank you enough. I've said this before for what you do to the patients, the community, and for the institutions. It's not easy to get to the COE level, and it is worth it. And I learned a lot, and I'm very happy that you guided us through to put a program like this. I can't thank you enough, and Stacy, thank you as well, and for your whole team.
We truly appreciate that. I'm going to bring this screen down now because we can edit it from this point forward, because that was a nice end for your website thing. So now, Goofy Lisa, it's the last day of Heart Month. I am wearing my Queen of Hearts sweater for those watching on video, but I got my vacation nails on, people. Tomorrow I go on vacation for a week. I will not talk to anybody for a week unless you want to talk to me about a boat drink down in the Keys. So I wish you all a very happy conclusion to Heart Month. I thought it would be nice to end the month with a launch rather than wrapping everything up, because HCM doesn't stop.
Yeah.
Our hair doesn't only happen in a month, and awareness doesn't only happen a couple of days a year. It's every day, it's all the time, it's what we do. So, Rupa, thank you for everything that you're doing for patients and to your entire team, and have a great end of Heart Month.
Yeah. Thank you, and have a good vacation.
Thank you very much. I'm very much looking forward to it. The Keys, here I come.